Thanks, Terry. Good morning. It's my pleasure to introduce our next speaker. Once again, Jeffrey spoke at an Accreditation Canada forum in November and was very challenging, so I know you look forward to his talk. The identification of challenges and the realities of healthcare and its delivery have been reviewed by a number of renowned and well-informed individuals over the past few decades. We all strive to find the answers, new directions, identify how we can optimize the quality of care for Canadians to ensure the best healthcare system in the world. Jeffrey Simpson doubts we have one of the best healthcare systems in the world, and I think Minister Horn has certainly reiterated that same message. The OECD numbers continue to challenge us. And I'm the first to say, given my perspective and work across the country, our reality is 13, probably 14 healthcare systems, which truly complicates our ability to coordinate initiatives and outcomes in an effective manner. That being said, we have a refreshing new perspective on our healthcare reality. In his book titled, and needs no introduction, seeing you all have a copy, in our healthcare system, the book Chronic Condition, Why Canada's Healthcare System Needs to be Dragged into the 21st Century. Here's an opportunity for further debate and hopefully identification of strategies and solutions. Themes such as the private-public issue and funding are addressed. Jeffrey's bio is in your agenda, so I won't review that. Suffice it to say he is a significant public policy commentator in Canada. He's been a long-time Globe and Mail columnist, a significant contributor, and has many ideas on how to fix things, which will be a great complement or complementarity to what we have just heard. So I'm very, very pleased to introduce Jeffrey Simpson to you, speaking on recommendations for improving the healthcare system. We must pay attention, and we're going to learn from Jeffrey. So welcome to the podium. Thank you.
First of all, I want to say thank you to this group for the work that it has done, because in the research that I was doing for Chronic Condition, I read a lot of the research papers that had been produced by this group, and some of them I found not just useful but formative. And that's the highest praise I can give to any association. So I have 10 points, and I'm going to spend about 2 minutes on each. So get ready. Okay, this is going to be rapid fire, right? Pay attention now. All right. Number one, I have a different title for it, but I'm going to give it a new title. It's called Do a Horn. What does that mean? It means that in November of last year, I was in Edmonton. I was addressing a group. Minister Horn came to give greetings. He was a bit late because there was one of those Edmonton blizzards in early November that we all love so much out there. So he gave a very simple, I'm very pleased that you're here. He spoke for 10 minutes, and he said something that nearly caused me to fall off my chair. He said, we have an expensive system that isn't nearly giving us value for money. Now, in this room, that's, I suppose, a non-controversial statement, but I can tell you, for a political person to say that over many years was to risk serious political injury and possible defeat, because we had been told, we had been conditioned to believe by all of our political people, by the blessed Mr. Romano and all the people who did research for him, that we had the best system in the world. I don't know how many times I heard it. And the more you looked at the international evidence, the more you just knew this wasn't true. And so to hear a minister of the Crown in a prominent province say, as a matter of fact, what he said caused me nearly to fall off my chair. And now, doing a horn is much more acceptable in polite company than it was a few years ago. So my first comment to you is banish fear. Do a horn. You are the leaders in civic society in the field of healthcare. And people ascribe a lot of importance to what people in senior positions of what I call civic society say about issues. You are not seen as being lobby groups. You are not seen as parti pris. Vous avez une certaine expertise, vous avez une certaine perspective plus ou moins objective. Alors si vous dites la vérité, je pense que les grands publics vont vous écouter. Ils seront à l'écoute de ce que vous avez à dire. So I urge you, do a horn, tell the truth, banish fear, tell folks we don't have the best system in the world. Parce que le point de départ d'un débat, c'est très important. Si le monde accepte dans n'importe quel domaine qu'on est le meilleur, il n'y aura pas de solution, il n'y aura pas de vrai débat, parce que le monde va se dire, ben, on est le meilleur, pourquoi débattre de la question ou des questions? Mais si vous commencez comme point de départ avec le fait qu'on est de loin, nous ne sommes pas de loin le meilleur au monde, il y a toutes sortes d'ouvertures, il y a toutes sortes de possibilités de lancer des vrais débats. Number 2, tell people that this is now the right time for fresh thinking. Why? A, all the governments have deficits except Saskatchewan, even Alberta. Number 2, for the next 10 years, and maybe longer, we're going to have slower growth than we had in the 10 years before 2008. That's what all the economic literature tells us about financial recessions. So instead of having growth that averaged around 3%, as we had in the 10 years before 2008, we're going to have something closer to 2% in the 10 years, and we're in that period right now. That will have a depressing effect on government revenues. That will make social choices harder. That will make issues of raising taxes more relevant. So explain to people that we're entering a new era. Thirdly, we now know what not to do. We know that buying change with a lot more money, which is the path that we followed post-Romano for almost 10 years, did not buy change. It bought peace, and it bought time. We know we can't do that again. We shouldn't do it, even if we had the money. So anytime a political person or anytime somebody in the healthcare world says that the answer to our problems is to put more money in, indexed at 6% a year, tell them that that is literally the worst thing that you could possibly do. We know that from experience. And fourthly, remind them that the population is aging, and that last year, for the first time, the baby boomers began to turn 65. And that although the costs of aging itself are manageable, as all the public policy experts say, provided we adjust the system properly, we haven't considered the unfunded liability of aging caused by the fact that there will be fewer people working whom we can tax to pay the additional cost, not just for health care, but for other things that older people will need. So those are 4 reasons why it's a timely point to change, timely moment to have a discussion. That's number 2. Number 3, we have to try, and this is extremely hard, to dehospitalize our system. The minister spoke about it. Maybe many of you know it. How do you do that is difficult. But you need to put in this system that which it has lacked for a long time, which is incentives. Behavior changes because of incentives, not from top-down management, but because people respond often to monetary incentives. So in my province, Ontario, you have these halfway houses of LHINs, which actually don't really control all of the delivery of healthcare. And so within the LHINs, the healthcare system is really driven by the hospitals, who attract the great and the good to their boards, who have access to the media, who have telethons on television, who are the crown jewels of their community. And woe betide any political person who wants to close a hospital or change its vocation to something like, let's say, an extended family health clinic. As long as the hospitals have their own boards, as long as the regional health authorities don't control the system, the hospitals will run the system. So the first thing to do from a public administration system point of view is to make sure the regional health authorities have the power and the budget, and to make sure that the hospitals are secondary to and subservient to the regional health authorities. I know how hard that's going to be. Put in place incentives in the healthcare budget so that the marginal dollars go not to hospitals but to the other institutional arrangements along the continuum of care, as was recently recommended in Dr. Shamir's report in Ontario, in which he said the budget for home care should go up for 4%. Now, he didn't go on to say, but it's implicit that the budget for other parts of the system can't go up at 4% because in Ontario at the moment it's being held to 2%. Anyway, that and when Minister Horn talked about the importance of family clinics, he's absolutely 100% right, but as long as the hospitals are driving the system, it's going to be very hard to pull that off, and he probably knows that better than I do. Number 4. The most difficult question, the most difficult word in the Canadian healthcare lexicon is private. The original health care was a deal between private professionals and the government of Saskatchewan, but we still have great angst about private. The fourth point I make is we have to discuss the word private in a sensible way. Put this comparatively. There's no system in the world that is moving in the direction of the Canadian system. All the other systems have moved or are moving away from the Canadian system, and to some extent we are trying to catch up with where they have been or are going. Public systems. And all of them don't have the hang-up about private that we do. We need to, where appropriate, consider private delivery of publicly financed services. To say this in Canada is to run a great political risk. In other countries, it is considered normal. The new normal in Sweden is to set up competitive models between private and public practitioners. Those of you who've been there, as I have, know it. If you're not sure about it, read The Economist's survey of the Nordic countries last week. They are not the old Sweden. They have decided that the best thing to do is to have a public system which encourages competitive delivery of publicly paid for services in a country with a long and honorable social democratic tradition. Where these services are appropriate. Last week, and I think you're going to hear more about this later, I stand to be corrected, but Janice McKinnon from Saskatchewan produced a report, or at least an essay, in which she said that the early results of the experiments with day private clinics in Saskatchewan, paid for by the state, show the same quality and a significant reduction in wait time. So what I say is this: if private delivery of publicly paid for services can meet 3 tests, then I think patients are agnostic, and I think we should be agnostic. First test, the quality is sustained and maintained, maybe even improved. Secondly, that the access is faster, which is what patients really care about in a patient-centered system. Because is this system about ideology or is it about patients? I don't think patients care about ideology, frankly. They care about the delivery. And thirdly, costs to the system have to be lower. If it can meet those 3 tests, then I think we should open our eyes and minds to that possibility. If it can't meet those tests, there's no point in going in that direction. Point number 5, which is an adjunct to number 4. We know, and the minister alluded to it, that we have a lower spending on long-term care facilities than the OECD average. And we know that the amount we're spending today is lower than the OECD average, but everybody knows on the continuum of care, as part of the dehospitalization of the system, that that's the direction we want to go. So the question is, how do we get this institutional situation improved? Home care I'll speak about briefly in a moment. In my province, maybe even in Alberta with its deficits, if you think that the government of Ontario is going to produce $1 billion to build long-term and nursing care facilities that we start needing urgently now because of an aging population, then you're not living in the same province I'm living in. What we need to do is to put out to private tender the construction and contracts for running these homes under public payment arrangements. Because if you wait for the public sector to build them, unfortunately, we're going to be running after the situation that we need to get resolved. Which just leads me into one sort of wider point. The state in our society plays a whole variety of roles, running from the state actually delivers a service. So for example, pensions, it sends everybody a pension check when they arrive at a certain point in time, all the way over to what I would call loose and light regulation. You all have cell phones. Well, the CRTC has a role in the rates that companies can charge and the arrangements and structure of the industry. They don't deliver anything, they regulate. Along a continuum, the state has many powers. But what we have done in healthcare is to insist that the state actually delivers in a wide range of areas involving the core of Medicare, outside of which, of course, it becomes US-style medicine, catch as catch can. And I'm saying let's be more realistic and flexible about the powers that the state has, the power to regulate, to monitor, to allow to have happen, to withdraw. In other words, it has strong regulatory and supervisory roles, and we shouldn't be afraid of them, but we should use them. Number 6, pharmaceuticals. We have, as you know, next to the US, the highest drug costs in the world, and it's a driver. And here I'm going to make my little pitch. You know that for seniors, pharmaceuticals is almost a universal need. 85%, the data I saw, of people over 65 Take at least one pharmaceutical. The older you get, the more you take. Ask most provincial treasurers, what are your biggest cost drivers for the next 5 years? And they're going to say, probably, if they're honest, the seniors drug plan that my province has. I have choices. I can withdraw some drugs from the plan. Good luck for the people who are taking the drugs. I can increase the deductible, and I can make it income related, as they're doing in Ontario. Probably will be done somewhere else. Not a bad idea, except that it doesn't give you the revenue you really need to deal with the forthcoming burden. So my sixth point to you is we have to think about this system of ours, not just in terms of raising tax dollars today to or borrow to buy a certain number of healthcare services in that year, which is a system, a way of financing things that can work reasonably well as long as the age spread of your population is about the same. But as soon as you begin to get more seniors, then the tax each year and borrow each year to buy more health care begins to get out of whack because the demand goes up and the number of people you can tax to pay for these services goes down. That's why we have to start thinking about a social insurance model to help pay for some of these additional costs brought about by the demographic shift, because the old system doesn't work unless you raise taxes on the people who are still there. When I say to my graduate students that I meet at the University of Ottawa, hey, get ready, we're going to raise taxes on you to pay for my costs as a senior, they go berserk. They say, we already have too high debts for students. Our fees are going up every year at 5 or 6%. You can't do that. And I say, no, sorry, we vote, you don't. We're organized, you're not. Politicians listen to us, not to you. So we want, and this is not, so we need to think intergenerationally. And that's why in this book, I've recommended that we have a national seniors pharmacy plan based on the Canada Pension Plan, which becomes the Canada Pension and Drug Plan, into which people pay throughout their working life along with employers and government, at the end of which, when you turn 65, 67, you get pharmaceuticals which are almost a universal need. And of course, there's a deductible attached. That would be the extension of the Medicare principle of Tommy Douglas, which Canadians are quite wedded to. It would be socially fair and it would be fiscally responsible. Otherwise, what's going to happen, like the people who say, let's have national pharmacare, okay, so we're going to tax the existing population to pay for the increasing number of seniors. And I've never seen how that economically works in a way that's intergenerationally fair. Number 7, simple bullet point, it's been mentioned, it's true, the scope and nature of practice has got to change to try to deliver care in a more cost-effective way at points of access to the system that are less costly to the system and in many cases better for the patient. And the structural changes that are going ahead in Alberta and Ontario are helping to move us in that direction. And reference was made before about, I don't think she didn't indicate she was pleading for her parish, but of course she was, the registered nurses to be able to do things through nurse practitioners and nurses that now are being done by physicians, and the same thing with pharmacists. All of that has to go forward. Incentives I mentioned. Again, we're always running to catch up to things because we think we have the best healthcare system in the world. Well, we don't. Other countries have introduced, as you all know, alternative-based funding for hospitals, which bring about more patient flow through the hospitals because the incentives in the system change. As long as you have top-down management of any large public system, I tell you, there will not be the kind of incentives for change that you need. You have to build incentives into the system. Funding incentives for individuals and for institutions. It's a basic rule. And that's now slowly happening in British Columbia and Ontario, perhaps in a few other places. But I have to tell you, as I try to warn people, it's so much easier to talk about these things than to do it. So in Ontario, they introduced these things. I won't mention a particular hospital. Hospital says this, okay, let's all get together. The surgeons say, yes, we'll do that. The nurses say, yes, we can buy into that with overtime payments. The orderlies, yes, it's all arranged. We're going to do surgeries on Saturday. Saturday surgeries. Can you imagine anything more radical than that? Apart from the rooms that are open for emergencies? Fine. Except that the anesthetists say, we're not working on Saturday. I mean, what is this? They earn $500,000 to $600,000 a year, the anesthetists. They said they're not going to work on Saturday. Walmart's open on Saturday. I'm sorry. But as long as the physicians, are paid by a third party whose rules and conditions establish what they do and are not directly line responsible to the hospital, you get this kind of situation. I'm on a university executive committee of a board of directors, and I've been on 2 university boards. Universities are very hard institutions to run, as any of you who are associated with them know. But they would be impossible if the faculty members said to the administration, well, actually, we've signed our agreement with some third party down the road there in Edmonton or Victoria, and you really don't have the kind of control over what we do and how we perform. We have barely any control now. It would be even worse if they didn't have a contract with us. So this is what I mean by organizational dysfunction in the system, and there's an example of it. Ninth, yes, absolutely, we have to change the way, through incentives, that doctors practice. The minister talked about that. That is absolutely correct. Again, moving towards different payment models of the kind, again, that's much more prominent in other countries as we run to catch up. And lastly, you have to benchmark, okay? You all know that in your institutions. But our system actually is awash in data, but there's a great institutional set of fears, I think, about actually benchmarking. Provinces, you know, they set up the health council and so on, but they don't really like benchmarking because, gee, maybe we wouldn't look so good. Regional health authorities don't tend to like benchmarking much because, gee, maybe we wouldn't look too good. Within medicine, people don't like to benchmark much because, again, you know, maybe we wouldn't look too good. The system needs to have a lot more benchmarks put in place. I personally favor, instead of some provincial clinical assessment councils, they're called different things, one national NICE, as the British have. After all, we're only 34 million people. Seems to me that instead of having one of these in 2 or 3 or 4 provinces, we should bring them all together. It's the same reason why we should have a national seniors drug plan. There are roles for the federal government. They are important roles if people are willing to articulate and think them through, including provinces, as to what those rules should be. And one way would be to create institutions that allow us to see in a comparative way how we're doing. Of course this is uncomfortable. In Sweden, they publish every year a book. It's about this size, which has a whole series of matrices for the 31 councils. I think it's 31, correct me if I'm wrong, my memory's getting addled. But anyway, all the municipal councils that deliver a lot of frontline care. And I asked the people who put this together what happens. They said, well, the first few years, people contested the data, which is perfectly normal, all right? And then we worked with them, and then we got more buy-in that the data was fair. Now what happens is that when the data comes out each year in the council areas where they're performing at the bottom, there's big kerfuffle in the newspapers. The physicians sit down with the hospital administrators and the frontline people and say, how are we going to improve, because this is embarrassing. So benchmarking is uncomfortable. Data comparison is difficult, but it is something that ultimately leads to system improvement if it is done in the right way. Alors, moi je pense que, pour mettre fin à mes remarques, on a appris des leçons importantes, qu'on ne peut pas continuer à verser des fonds extraordinaires dans le système comme nous avons fait depuis l'accord de 2004. C'est la raison pour laquelle je prévois, et j'en suis absolument convaincu, que dans les années à venir, dans les 5 années à venir, peut-être les 10 années à venir, quand les ressources ne seront pas aussi évidentes que dans le passé, qu'il y aura plus de changements, plus d'initiatives, plus d'efforts concrets d'apporter à ce système, ou à nos systèmes, des changements que pendant la période où il y avait beaucoup d'argent. Et c'est la raison pour laquelle je suis sorti de mes années de réflexion un peu plus optimiste quant à la capacité de faire des changements qui s'imposent à notre cher système de santé, et parce que le monde comme M. Horn sont prêts maintenant à aborder la vérité au lieu de véhiculer des idées folles. Et deuxièmement, parce que le manque de ressources va nous forcer de songer beaucoup plus profondément à des changements qu'il faut apporter à notre système. Thank you very much. I'm happy to take a couple of questions.
Thank you so much, Jeffrey. 10 solid points for us to reflect upon. I'm going to turn the first question comment to Shalom Globerman from the Patient Association of Canada. And I'm afraid this is probably going to be our only public question with Jeffrey, just because we're sliding a little bit behind the time. But Jeffrey will be here, I hope, through the break to sign and connect. Thank you.
Thank you very much. I must say that in preparation for asking my question, I read your book a couple of times.
I can ask for no more.
Yeah, and enjoyed it very much. And I thought that it was full of really important insights. I think the big one is that our healthcare system was built on hospitals and paying for doctors and for medically necessary services. So it was really focused on acute care. And the second point I think that you catch really well is that our growing population of old people all suffer from chronic diseases. So our system was designed to deal with acute diseases and to deal with acute infectious diseases, and primarily it's now going to be forced to deal with chronic diseases, and that's really the basis of the inappropriateness that you talk about, I think. The thing that's interesting to me is that you spend one paragraph in the book talking about patients' ability to speak up for themselves and to start to push the system, and say that that won't work. I'm interested in that, because it seems to me that that's the biggest movement that's happening now that patients are beginning to organize and to speak for themselves and to present their perspective on the system. They're joining as patient advocates, they're becoming important in making these decisions, and they're bringing a perspective that the people who are the leaders of the system don't have. It's a perspective that is that of the patients and those people who give them care. So I wonder what you think about that.
Well, first of all, there are a number of things that I didn't cover, one of which is mental health, about which I know almost nothing. Another is Aboriginal health, because that would require a whole other book. And I didn't speak much about rural health. So it is a book that is much concentrated on urban health, but that is where the majority of the population live. And to your point, so I'd like to learn more about these patient advocacy groups. I'm, as the Americans would say, from Missouri on that. Why do I say that? One of the biggest challenges, I might even say the single biggest challenge that public administration has in the country, which does not just relate to healthcare, but also to higher education and to the law, which are the three big, well, education and generally, the three big drivers of any provincial budget are those three. And what do they all have in common? What does the law system, the education system, and the healthcare system have in common? Subject to you correcting me. They all have the following dynamic. Taxpayers wear three different hats: litigant, or somebody involved in the law system, student, or patient. And generally speaking, they present to these institutions as individuals. I want to get a university degree, I choose a university, I arrive. I have some problem with justice, I arrive. I may have counsel. I go to the healthcare system because I personally have an ailment. My group doesn't have an ailment. The people on my neighborhood don't have an ailment. The people at my workplace don't have the same ailment. I have an ailment. So I go. And they find in these three systems huge and complicated institutional structures that have been shaped like rivers for years, largely to satisfy not the prerogatives and needs of the individual who presents, but the providers who deliver the service. That's why every year the Chief Justice of Canada gives the same speech to some group of lawyers across the country and says the access to justice is too slow, the cost of justice are too high, and the wheels of justice turn too slowly. Same speech. Right? And in Ontario and British Columbia, they've had reports, serious reports done about the justice system that revealed all of this. And what happened? Almost nothing. Why? Because the judges were highly resistant, and the lawyers blamed the judges, and the judges blamed the lawyer, and not much happened. In higher education, if we had a truly student-centered post-secondary educational system, and I say this with some degree of seriousness because I've been involved in different ways in universities, you would never have a system where the students present in first year and get thrown into classes of 400 to 800 students. That's not a student-friendly system. That's been created because the professors have incentives. I won't go into it, but that's the reason, okay? Similarly in healthcare, individual patients arrive in emergency or wherever, and they confront an immensely complicated system that has not been well coordinated over a long period of time, and it's structured over a long period of time, largely to suit the convenience of the doctors, the unionized workforces, and to some extent, administrators. Now, you're going to tell me that there's now a new movement where patients are going to group together and advocate for their particular interests. Well, I'd like to hear more about that, but I say thus far, that hasn't happened. If it's happening, great. But the cancer patients don't have the same interests that the person who has a cut and needs to go to emergency. And the cerebral palsy people don't have the same problem that somebody else who has a particular chronic disease has. So it's very hard to mobilize individual patients to change these systems. And it applies in the same dynamic for law, for higher education, K-12, and also for the healthcare system. It would be nice if you succeeded more, and I encourage you to do it. Thank you.
Thank you.